Aerosol is the suspension of liquid or solid particles in gas. Aerosol therapy is the delivery of aerosol particles to the respiratory tract. The three main uses of aerosol therapy are using aerosol drugs to humidify gases, to move or clear secretions. 4 pros of aerosol are smaller doses, rapid onset. They target the respiratory system. They have less systemic effects. 3 factors of aerosol drug delivery are stability, penetration, deposition. Stability is how well aerosol particles remain in suspension. Penetration is how deep it goes in lungs. Deposition is which particles stay in the lungs. One major factor for lung penetration is particle size. Characteristics of particle sizes are count mode, count median diameter, mass median diameter, and the geometric standard deviation. The count mode is the most frequent particle size. The count median diameter is the particle size that evenly divides the number of particles. The mass median diameter is the particle size that evenly divides the mass of the particles. The geometric standard deviation is the measurement of distribution of dispersion. 3 mechanisms of deposition are inertial impaction, gravitational settling or sedimentation, and diffusion. Initial impaction is based on size and speed. Particles bigger than 5 micrometers hit the walls of upper airway and the bifurcation of the lungs. Gravitational settling or sedimentation is based on size and time. Particles between 0.5 and 5 micrometers slow down and settle in small airways. It increases with slow inhale, large inhale and a long hold. Also, the time it takes the particle to settle is the square root of the particle size measured in per second. Diffusion is based on time and random motion. Random motion is caused by collision with gas molecules. Includes particles smaller than 1 micrometer. The particles may diffuse in lungs or may be exhaled because of high stability. This was in the book and seems like something that would be on there. 3 main aerosol devices are the metered dose inhaler or MDI, also known as a PMDI, the dry powder inhaler or DPI, the small volume nebulizer or SVN. 3 types of MDIs are the conventional MDI, the breath-actuated MDI, and the soft mist inhaler. The conventional MDI has hand-breath coordination. It is primed by releasing 4 doses. It uses a HFA propellant. This is the structure of a conventional MDI. The breath-actuated MDI is used if the patient has difficulty coordinating the conventional MDI. Its drug is released when inspiration occurs. This is the structure of breath-actuated MDI. The soft mist inhaler or the RESP has no propellant and no breath activation. You must prime before use and if not used for 21 days. It has less deposition in the throat. It is also expensive. This is the structure of the soft mist. 8 factors that affect MDIs are loss of dose if it is stuck in the valve, shaking the canister, timing of actuation which involves coordination, the loss of prime, the storage temperature, the nozzle size and cleanliness, the breathing technique used, either open or closed mouth, and the patient characteristics. MDI accessories include 2 reservoir devices, the spacer, and the valve holding chamber. Both extend MDI away from mouth. The valve holding chamber has a one-way valve to hold the aerosol until it is inspired. The pros of reservoir devices are they increase vaporization and evaporation of large particles, decrease oropharyngeal impaction, slow the particles down, make coordinating easier, increase dose deposition. Also, children can use with a mask, and they are good for dyspneic patients. three types of DPIs are: the unit dose, which has a one-dose refill; the multi-unit dose, which has a multi-dose refill; and the multi-dose, which has a powder reservoir or a strip of doses. Four factors that affect DPIs are: intrinsic resistance, which is how hard you need to inhale for the proper dose to come out; inspiratory flow rate, which is how hard you need to inhale to receive the proper dose; humidity, because if the device has a reservoir the powder could clump; clinical efficacy, meaning they are just as good as MDIs. Small volume nebulizers family tree. Jet nebulizers have small reservoirs. They are gas-powered. And they are also known as the handheld nebulizer, or HHN. The jet nebulizer with the reservoir tube is cheap and widely used. It is also wasteful. The patient only receives 10 to 20% of the dose. The jet nebulizer with the collection bag has no aerosol wasted because of the bag and the one-way valve. The breath-enhanced jet nebulizer has two one-way valves and a reduced aerosol loss. The mechanical breath-actuated jet nebulizer uses an inspiratory force that triggers the device to create aerosol. The manual breath-actuated jet nebulizer was the first generation of breath-actuated jet nebulizers. Mesh nebulizers move liquid through mesh or a fine plate with holes. They have no baffle system, and they use an aperture plate or an ultrasonic horn. Active mesh nebulizers have an aperture plate with 1,000 to 4,000 holes, and they vibrate with a piezoceramic element that is surrounding the plate. Passive mesh nebulizers use an ultrasonic horn. The newer versions use the adaptive aerosol delivery, or AAD. One device is the iNeb, which is portable and battery operated. The iNeb also delivers a preset volume of 0.25 to 1.4 milliliters. Ultrasonic nebulizers are electric powered. They have a high output and are not used often. The small particle aerosol generator, or SPAG, has a large 300 milliliters reservoir. It is used with ribavirin. The RESP guard has three one-way valves and a filter to eliminate air contamination. It is used with pentamidine. 6 factors affecting nebulizers are the dead volume, which is usually wasted solution; filling volume, because nebulizers need higher amounts of solution for the device to work properly; effective flow rate and pressure is how the flow affects the treatment time; type of gas power, because different gases produce different effects on devices; the device interface used, in which case the mouthpiece is most effective but it can't be used for babies and is uncomfortable for long treatments; the type of solution, because physical characteristics of solutions could require different flows; age ranges for devices. FVN is for 2 years or younger. MDI with a chamber and a mask is for 4 years or younger. MDI with just a chamber is if they are older than 4. DPI is for 5 years or older. MDI is if they are older than 5. Breath-actuated MDI is also if they are older than 5. That's the end of the video. I didn't include the instructions for treatment, so don't forget about those. If you are still watching these videos, good luck.